Well, I came to serve Uncle Sam in Wichita Falls, Texas. And I graduated from Georgetown, done all my training in Georgetown, Washington, D.C. And I was 2 years in Wichita Falls. Turned out that Charlie and I had a mutual friend. Dr. Schultz and I had a mutual friend. He trained with him at Mayo, and he came down and trained with me at Georgetown. And Charlie was a year ahead of me, and he was already here in Waco. And Dick Spangler called him and told him that I was up in Wichita Falls, because the very most difficult thing about Waco, Texas was to be able to recruit. You could not recruit a doctor. It was impossible for years. They all said the same thing. How many million people are in Waco? That was the end of the conversation. All the young cardiologists. But we got here, and the first few years, almost everybody that we had a Waco connection. Brian Ainsworth's daddy was a general internist here in town. Bobby Crosswaite's father was general surgeon. Rob Angel and Bobby Crosswaite trained together. That's how they got here. And they decided that we were going to have a surgical program. And there was no surgical program between Austin and Dallas. And nothing done at Scott White at the time. So we forged ahead. Things changed rapidly. I always say that I was lucky enough to practice during the golden age of cardiology. Everything changed in cardiology. Intervention started in the early 80s, very minimal. It wasn't, the Houston Surgical Group started doing bypasses. Mayo had been doing some bypasses, but those were really the only two institutions that were doing bypassing. When I finished my training, the very last day I was at Georgetown, I did my first coronary arteriogram. The only one I ever did in training. They just didn't have a surgical program, and there wasn't any need. We were basically pediatric cardiology, the complex pediatrics. So, but it evolved very, very quickly. Charlie and I hit it off well. In '73, we formed a partnership. In '74, we formed Waco Cardiology. And we've had some hellacious experiences over those 50 years. It all started, Charlie had everything organized when I got here. I had come down maybe 4 or 5 times for a week at a time from Wichita Falls so that he could go to a meeting or go to vacation or something. And then I came down, I got early, I didn't get early discharge. I took all my leave that I had in the Air Force in June of '73, but then I had to go back in the middle of June and sign out of the Air Force. So I wasn't here. When I got here, we were on the 7th cath. My first cath was a woman named Janie Rezak, and I cathed her in August 3rd of 1973. We had an office down in the basement of Hillcrest and an office on the 3rd floor of Providence, of the new Providence. Actually, the middle-aged Providence. When we started here, we were in the old Providence. And ultimately they tore that down, but they remodeled the middle part of it for a while, for a while it was used. And then we moved across town. that was a step forward. That's when we started thinking about we needed more space.
So Becky, can you kind of tell us how you came to be? Tell us your story.
Well, my dad had a heart attack, and I had just walked out from seeing him, and so I got on the elevator. Dr. Schultz got on the elevator, and he asked if I wanted a job. I said, I guess. So that's how I started there. And I did some non-invasive, and then I would work non-invasive in the morning and cath lab in the afternoon. And I got full-time in the cath lab, which was a blessing. I
So
liked it.
were you right out of high school whenever you started, or?
She was still in high school.
When I started in 74, and I worked a year on the floor, and then I went to cardiology.
Okay.
So, and a lot of changes, a lot of equipment changes, anything that Waco has today, they ought to be very thankful to these two guys because they developed it all. And you could put Waco's cardiologist among any in the nation and they'd be right there with them. And the equipment in the lab has changed tremendously. The imaging equipment, the stuff for angioplasty, everything's just so much better and everything. So everything that the American Heart Association has done to raise money and these guys have done to raise money for all the hospitals has been really well worth it.
During cardiopulmonary school, I fell in love with cardiology, the cardiology part. When I was sent to school, I was being sent there to run a blood gas lab at Wilford Hall Hospital down in San Antonio, which I had already been running. I also got to meet Dr. Cashin, who eventually came and joined their practice. And he and a friend of his knew that I was getting out of the Air Force about the time they were looking for a cath lab person to come up and work in the cath lab. They called and I took an interest in it and I ended up here in 1975. I always thought that they didn't really do heart caths until I got here, really. They'll probably argue that point, but
The real change in cardiology in the lab was when we got rid of the cradle. Initially, the X-ray tube was top and bottom fixed. It didn't rotate or move. It was fixed. So if you wanted to get side views of the patient, you had to move the patient. So they developed this cradle. You laid in it and strapped across the chest and legs, and you could rotate one side to the other and take pictures.
that was a major advancement when we got our real first heart cath lab. And it had an X-ray tube and image intensifier that rotated around the patient instead of us having to rotate the patient around the tube. It made a large difference. We were able to get much better views of the coronary arteries and make better diagnoses of the coronary arteries, which helped them make decisions, and it helped the surgeons make decisions on where they were going to bypass and such. That was one of
The image intensifier, just as it's spectacular now. In the TV, I mean, it wasn't like that in the early days.
Not at all. You really didn't make a diagnosis off the imaging system while you were doing the heart cath. You made sure you were getting the heart on the 35 millimeter film that we ran. We ran somewhere between 300 and 500 feet of 35 millimeter film on every heart cath. And we take that out afterwards, develop it, and we put that on a projector up in the dark room upstairs. And that's where they would make the diagnosis.
It wasn't instantaneous.
Really?
No.
So,
And all the hemodynamics were on an E4M machine,
Lots of
which,
paper.
huh?
Lots of paper.
Lots of paper, foot wide paper, reams and reams of it. during my fellowship, you took that home at night and your wife ironed it. That's how it got dried.
Really?
And then you analyzed it the next morning. With the two of us, it was very time consuming to be the only cardiology in both hospitals. You know, we changed every day. Monday, Wednesday, and Friday, I went to Hillcrest, Charlie went to Providence. Tuesday, Thursday, Saturday, we changed. So we knew every patient, the two of us knew every patient, and that actually was good. But our first few years, we were cardiologists, mainly. But we also ran the respirators, we did pulmonary, we did renal, intensive care. There weren't any other subspecialists. Providence had the first cap. You know, that was the segmented or segregated medicine. Hillcrest did babies, something else, orthopedics.
Trauma.
Providence did psychiatry and cardiology.
We utilized radiology's special procedure room for a good 3 years, I think, before we opened up our first real cath lab. And we designed that and bought it from the Phillips company, same people we have now. We've been through others, but we've always come back to Phillips. They went out of their way to do things in our cath lab that were different than other places because we wanted some things that were different, and they did a good job with ours. Up until our cath lab, they had always just put their imaging monitor up by itself, and they put that on a boom. And before that, it was on a roll-around cart that they would pull up next to the patient's table, and you would look at that as you were manipulating catheters and such. Well, they put it up on a boom so that you could actually work over the patient and see what was going on there. Well, the hemodynamic monitoring system was over by itself, and that's usually where I was, and I would let them know whenever they went from one chamber to the next, and the pressures changed, and I would record it and such. Well, they couldn't see that, so I would have to let them know that, unless they looked around me, and okay, we're where we think we are. And so we had them put a second monitor up on the boom so that imaging and monitoring were both right there in front of them. And it was one of his ideas to do that. And I asked the Phillips people, is this something we could make happen? And they said, yeah, maybe. So their engineers kind of worked some things out, and they made it work. And it was unique enough that they took pictures of it and sent it to all of the rest of the Phillips engineers so that it was being done in other places. If it had been done somewhere other, in some other part of the country, it might have happened before us. I can't really say that, but I know we were the first one in Texas, and because the R.P. Kinslow company was Phillips back then, and they were the ones that we were dealing with, and they developed it because of our cath lab.
In the early days of catheterization, Dr. Schultz and I trained in diametrically opposite types of a program. I trained with Dr. Proctor Harvey, who we did one cath a day from 7:30 in the morning to 4 o'clock in the afternoon, every day, same patient. We did transeptals on everybody. You go in, and we did them from the arm, transeptals.
Wow.
Yeah. It's the only way. I never did a Judkins till a year or two after I started here. I never went in through the leg. Never.
How did you bend a rock and roll around the arm?
Huh?
How did you bend a rock and roll around?
You can get it there. I promise you. I promise you can.
Wow. That's amazing.
We go in with transeptal. You go in the right side of the venous side of the heart, and you poke a hole in the atrial septum between the two chop chambers, and you put your catheter over there,
So
and we recorded sound
it's the only way you can get there.
every patient for years. And that was how they established what was making that clicking sound, was by that kind of stuff. But Dr. Schultz, on the other hand, they were more like the Houston program, volume. They did a lot of caths a day. And I never did more than one cath a day in my whole training program. 2 years, I never. But, you know, you use every bit of information that you obtain, and you can integrate it. And both sides had great merit.
And when we first started, I mean, we not only had to finish up the cases, process the films at night, but then we had to package sterile items. We had to put 4x4s in packages and seal them and send them downstairs. So we worked sometimes till 10 o'clock at night.
Routinely.
And a lot of things, I meant, like we had to redo all the equipment. And then when we did the angioplasty, we'd take the 35 millimeter film and we'd have a pre-picture that shows the blockage, and we'd have to cut that out and then splice everything back together. And then we'd go and find a picture afterwards. We'd have to take that out, splice the film back together. Then we had to go and make pictures for the patients at night. And so then you'd have a little piece of paper and you'd go in like this for the lighting and everything. So we ran a lab too, a photo lab.
Unfortunately, I had some experience with that. And I mentioned it to Dr. Rogers one day. He said, that's a good idea. Why don't we do that for everybody?
So what do you think about all the technology that's come up through the years?
Oh, it's just amazing. It really is. I mean, you went from some wires that you had that when you started doing an angioplasty, you would think that's the wire, you know, and the equipment, you could barely see it. And then you'd put in the angioplasty balloon in, and you would inflate it, and then you'd have to wait like 30 minutes because you could get the recoil of the artery back. And then the stents came about. And when we did the stents, the first stent that we put in, we would take them to the ICU and we would leave them bed rest for 3 days. We would roll them back and forth, and we had a certain dextran medicine we gave them to help keep everything open. And now they have a stent and they go home the same day.
The difference in the treatment is what really has changed. When we came here, there was just one gospel. You had a heart attack, you were in the hospital 21 days. You didn't leave. 21 days in the hospital. That was all over the United States. And didn't cath for 3 months.
After a heart attack?
Right. It's evolved from that, but that's what was considered gospel in the early 80s and in the early 70s.
Now we have them in the cath lab while they're having a heart attack, and we're fixing them, and they go home the next day.
A lot of times they can come in from the helicopter, and we've unloaded them hot too, where the blades are still going, and we'll take them out and bring them to the cath lab and do their case. And I mean, it's instantaneously when we open that artery, it's like, oh my God, I feel so much better.
And I know before angioplasty, whenever they first brought us a 16 millimeter film of an angioplasty being done, we were sitting there watching that like, that's the most dangerous thing I think I've ever seen. They were really approaching the coronaries and sticking wires down there. You don't do that. You just don't do that. You put your catheter up there gently, you take your pictures, and you get out, you know, before something bad happens.
I think the change in the going from 21 days to 21 minutes is probably the most radical change that, you know, I've seen. Of course, early on, there was no intervention. There was no hope of opening up the artery. You just let whatever damage heal, and and then you went in and took pictures. But I think that the technology of the angioplasty, doing legs, doing carotids, doing renal arteries, I think that just was amazing.
Everything that's evolved since we started doing this. It's light years different. There's nothing even close to what we started off with and what we're doing now. Some of the technology, you just have to see it to believe it. And we can put catheters inside people now, and we have a magnet underneath the table, and they have sensors on the patient, and we can recreate the left atrium just by moving the catheter around inside the patient. And then ablate wherever the bad signals are coming from to make the arrhythmias that we used to think were untreatable.
I think the thing I'm thankful for is how well the hospital stood behind us and supported us. They always came through. They're very supportive, both hospitals.
Like you said, if we hadn't had the support of the hospital to do those things, it never would have happened.